So good morning to everyone. The second topic for today is clinical challenges in compensated and decompensated cirrhosis in sarcopenia. So the contents would be as follows. So sarcopenia has already been very nicely elucidated that it is commonly present in cirrhotics. About 30 to 70% of them is the prevalence, and it is, affects the survival as well as quality of life, outcome after liver transplant, as well as other complications of cirrhosis. However, the definition of sarcopenia over the years has evolved, as you can see here from 2010 up to even now 2019, when initially it was considered to be a part of a low muscle mass with physical performance, and then eventually it was with low muscle strength and muscle mass as well as physical performances. So the pathophysiology, which was already discussed, is multifactorial, and I think that is what is important to be kept in mind. One of it is skeletal muscle, which was discussed in detail. The others would include reduced intake. It would be malabsorption. Malabsorption could be due to various causes, especially in cirrhotics, including ascites. You can have physical inactivity, which is another reason why you have more accumulation of toxic metabolites. You can have systemic inflammation, which plays a part, which leads to excessive muscle breakdown, as well as you will have reduced clearance of ammonia as well as other toxic metabolites, specifically from the skeletal muscle, from where most of the data is originating for sarcopenia. So when you talk of compensated cirrhosis, what are the clinical challenges that you would face? And what comes to mind is, of course, early diagnosis of sarcopenia in cirrhosis, the mode of testing, and what implications would that have when you find out that a compensated patient has sarcopenia. So this is a case scenario which commonly we would find in the OPD. A compensated cirrhotic comes to you, his MELD is 12, he has no other decompensation, BMI is well within normal range, he exercises regularly, but as you probe him further, he does say that there is difficulty in gaining muscle mass, and he does feel most of the time. He's not on any diuretics or beta blockers as such for other indication. So the first thing that comes to your mind is, does this patient have sarcopenia? And if he does have sarcopenia, which test would I use? And these are some of the commonly used tests that we do at our own place. So this is where the terminology comes in. And before that, I would also tell you that most of the analysis that we do, which is including the DEXA scan as well as the bioimpedance analysis along with CT MRI, what does it look at specifically? So when you're looking at the CT MRI, you're specifically talking of the muscles only. Then you look at the DEXA scan, you're looking at the lean muscle mass. And as you go on to the bioimpedance analysis, it also includes a fat-free analysis. So this is important when you're ordering a test for sarcopenia, especially in these scenarios. So coming to the first one, which is pre-sarcopenia, this is a term which is used in general, in principle, in sarcopenia, but there is low muscle mass without any impact on muscle strength and physical performance. Now these can only be identified by techniques which look at muscle mass, but if you can see the difference between pre-sarcopenia and sarcopenia is that pre-sarcopenia is just the reduction of muscle mass, whereas sarcopenia also includes muscle mass, strength, and as we saw, even performances. And severe sarcopenia would also include physiological reduction of reserve. So it's important to identify this entity. Not much is known about it or not much is read about it. However, even cirrhotics, as recent as 2021, there has been few studies from the Japanese population which has looked at about 335 patients, and as you can look here, 95% of these patients are cirrhotics and child A cirrhotics. So they're all well compensated cirrhotics. And most of these were older, about mean age of 55 to 57, were females. And they did predict that presence of pre-sarcopenia included low physical function, physical bodily pain. And as you look at physical functioning and role of physical pain, it would be limitations of physical activity as limited as walking, dressing, physical health. So whenever a patient does turn up to the OPD and complains of mild weakness, we may be actually missing out on an entity called pre-sarcopenia, which may have relevance in chronic liver disease. Another trial, another study which was done in Japanese, again recently in 2016, where they looked at CT scan to look at the muscle atrophy. So as I had mentioned earlier, there are various tests that you can do. Of course, CT, even though is one of the primary modalities of diagnosis, because of the excessive radiation that it causes, it cannot be as a first line, but yes, when you're using it for other indications, it can also be used to diagnose pre-sarcopenia. And again, in this study, if you look at, nearly 40% of the child A patients had pre-sarcopenia. So nearly half of child A patients who are well compensated, who probably have no other issues, also deal with pre-sarcopenia, which could have future implications, though much more needs to be known for this entity. And these are some of the other parameters like BMI, age, albumin, as well as the use of branched-chain amino acids which are associated with pre-sarcopenia. The other common problem that you normally face is sarcopenic obesity. So patient walks in well compensated. In fact, his BMI is well about 32, 33. He's well built. Our conventional sense says that he's actually a very healthy human being. However, sarcopenic obesity is a decrease in muscle mass in the setting of an increased fat mass. And as you can look here, the prevalence is nearly more than 1/3. It's 20 to 35%. So most of your NFLD patients who consume ethanol as well as have NFLD, these are one of the strongest risk factors for developing sarcopenic obesity. And so one of the factors that is sarcopenic obesity is the metabolic component. As it was being discussed, you have insulin-like growth factor 1, you have the other metabolic parameters which are involved. So obesity and sarcopenia and the aging process, they all cause an increase in the intramuscular adipocyte content, also called as myosteatosis, which was discussed. There is decrease in muscle efficacy as well as efficiency. All of these leads to sarcopenic obesity with increase in insulin resistance, and thereby the contribution of an advancing age along with sarcopenia are some of the reasons why you have a low muscle mass, low muscle strength, you have low physical performances, and you have increased visceral adiposity. When you look at the mechanisms, I think it is important to concentrate on the fact on the left-hand parameter, which looks at the dysbiosis aspect of it, where there are increased lipopolysaccharides. You have the term myosteatosis, which I just mentioned was the excessive accumulation of adipocytes in the intramuscular. You cause an increase in leptin, adiponectin, as well as inflammatory cytokines and insulin resistance. So this is one of the factors that are key in play when you're dealing somebody with a compensated patient who's otherwise has a high BMI but could still turn out to be sarcopenic in these scenarios. Some of the studies that have been done on myosteatosis as recently as 2020-2021 have looked at the intramuscular adipose tissue accumulation, and they have shown that increased intramuscular adipose tissue concentration leads to increased liver dysfunction, leads to reduced survival, increase intraoperative complications. It also leads to increase in bacteremia. More of myosteatosis and sarcopenia were independent risk factors for hepatic encephalopathy, something that you see mostly with decompensated cirrhosis with excessive sarcopenia. So the second part of the question was, what tools would you assess if you need to assess the muscle mass? And this is where the conventional algorithm using the anthropometry, you have the bioimpedance analysis, you have DEXA, and you have the CT. And most of these tests that have been done have their advantages and disadvantages, but I think we all agree to the aspect that DEXA as well as CT scan are some of the modalities that we need to use when you are actually assessing a patient in sarcopenia for chronic liver disease. BIA as well as DEXA are limited by the fact that fluid retention may cause spurious values, even though if you use the lean mass, you may actually be able to measure it correctly. A short slide on DEXA, and this is a live patient that you can see on the DEXA, and what we actually look at is the appendicular lean mass. So the appendicular lean mass that you normally need to have is less than 7.26, for females is less than 5.45. So if there's anything more than that, then it does indicate that there could be presence of sarcopenia. Then you have the body composition analysis, where you have the segmental body composition analysis. That said, one of the fallacies was that if there is increased ascites of fluid retention, you may have to use segmental bioimpedance analysis to correlate with sarcopenia. And again, this is of another patient that has been used, and this is commonly used here at our hospital. The other was CT scan, and a CT scan is one of the direct methods of assessing body composition, and also happens to be the gold standard for assessing muscle mass. It is one of the most widely used methods in cirrhotic, even though it cannot be still prescribed as first line because of the increased risk of radiation as well as cost. And there are various regions where you can actually look at these images. One of the most important areas is the L3 vertebra. You have also the paraspinal muscles that can be used. You have the transverse abdominis. You have the external internal obliques that can be used for assessing. But most commonly it is the L3 vertebra which is used for the analysis using a software for sarcopenia. So the last question that comes to our mind when we're assessing all of this is sarcopenia same all over the world? We follow guidelines which are primarily from the European cohort or from the Western cohort, but in the Indian perspective, what we need to keep in mind is that the median body mass index of Indians is around 21.6, which is probably similar to the other Asian population, but is much lower as compared to the Western population. The Asian and the Indians have a higher percentage of body fat as compared to the West, and the muscle mass is much lower in Indians as compared to the Caucasians. So it's thereby implying that probably we need a separate set of values to sort of say whether the patient has sarcopenia or not. A few studies, I think one which was published in 21 showed that these were some of the values of skeletal mass index along with hand grip strength, and they had described it as Asian cutoffs. This was in normal set of population, and as they had derived that these are all normal patients, they have lower muscle strength as well as muscle mass as compared to the Western population. But we also have data from ILBS, and this was a study which was done in 2017, where looked at alcoholic liver patients. And as you can see here, the cutoff for the skeletal muscle mass was much lower than what we normally have for patients with the Western population. So this study does also tell us that you need Indian cutoffs for diagnosis of sarcopenia as compared to the Western cutoffs. Now, the other aspect that comes to mind when you look at sarcopenia is, do you recognize sarcopenia early, and what's the implication? And that is where the inclusion of MELD sarcopenia, and this was a topic last time, where MELD sarcopenia predicts mortality. And this was a study in 2015 which looked at 669 cirrhotics, almost 50% had sarcopenia, and MELD was a predicted mortality. However, interestingly, MELD in patients with 3-month mortality were the ones who had MELD which was less than 15 as compared to the ones who had MELD more than 15. So this implies if you include MELD and you include sarcopenia early in the diagnosis or in the progression of liver disease, it will have far more implications as compared to when the patient is already decompensated, where the patient already has other complications of liver disease. This was again another study which looked at the impact of sarcopenia, and it even compared with the HVPG values. And as you can see here, sarcopenia was not a prognostic factor as your liver disease started advancing. So most of our conventional thinking is that as the patient becomes more and more decompensated, the sarcopenia increases. But what we don't realize is as the MELD increases, the HVPG increases, and child cirrhosis increases, sarcopenia is probably of limited value. If you include it early in your setup, it probably indicates far more other implications as compared to as if you include it late. The other thing is again something that was done in ascites, where again these patients are primarily patients with LSM of more than 10 and available CT available, and sarcopenia was correctly able to predict ascites as well as predict mortality. And these are patients who are primarily compensated, who really don't have any much of decompensation. So the message is that if you have to include this in compensated cirrhosis, include it early, identify it early, look for signs for sarcopenia, which may have far more implications versus a decompensated cirrhotic at this end of play. Now, when you look at decompensated cirrhotic, well, of course, sarcopenia, as we all know, is associated with increased decompensation, increased hepatic encephalopathy, as well as affects the post-transplant outcomes. If you look at the association with decompensation, it because of portal hypertension, catabolic state, synthetic dysfunction, chronic inflammation, causes increased higher risk of decompensation, ascites, hepatic encephalopathy, liver transplantation-related deaths, as well as affects the survival. Some of the reasons why that could be is because it could be either cirrhosis related, which could be a synthetic dysfunction, it could be hyperammonemia, it could be even other systems which are involved, which include metabolic, insulin resistance, endocrine dysfunction, it could be malnutrition, it could also be due to the fact of environmental and physical inactivity, all of which leads to increased decompensation, healthcare utilization, decrease in health quality of life index, as well as adverse post-transplant outcomes. So this was an ACLF, again multi-organ failure predicted muscle loss as these patients. So sicker the patient, more the chances of sarcopenia, more the chances that there'll be adverse outcomes. And various studies over the years have shown that as it has serious implications on survival with the presence of sarcopenia. Now coming to the most important aspect, which is hepatic encephalopathy, and the previous speaker was speaking about the skeletal muscle, and this is where hepatic encephalopathy and skeletal muscle can be involved, because it's an important predictor for hepatic encephalopathy, which is oftenly missed. It is under-recognized, as well as there have been various studies which have now shown that nearly 40% of patients with hepatic encephalopathy actually have sarcopenia, and that is not well addressed. So these are some of the studies over the years, and as you can look here, hepatic encephalopathy was in 46%, 29%, 30%, 60%, and 70%. So it is important to recognize that once the patient is sarcopenic, the incidence of hepatic encephalopathy is high. And some of the reasons why that could be is because of the skeletal muscle mitochondrial dysfunction, which is hyperammonemia induced. So very nicely we had shown in the last speaker that how the skeletal muscle increases, ammonia toxicity is increased, you have increased myostatin, you have reduced IGF levels. So if you look at, there is a reduction in skeletal muscle ATP content, there's an increase in reactive oxygen species. You also have an effect on the myotubules. So once ammonia is generated inside the muscle, it actually uses leucine to get inside the cell. And this is one of the reasons why you have decreased branch in amino acids, and that's the reason why you need to supplement branch in amino acids in patients with hyperammonemia. And all of these increase myostatin, cause a decrease in protein synthesis, and one of the reasons why you have sarcopenia. So it is important to realize the skeletal muscle has a lot of implications when you're looking at hepatic encephalopathy. And this was a rat model study which had shown that if you use ammonia lowering measures, so they used 4 weeks of L-ornithine aspartate, it did improve muscle fiber size, lower plasma, muscle ammonia, probably due to the increased concentration of leucine which was present inside the skeletal muscle. So all of these does indicate that when it comes to skeletal muscle, hyperammonemia is one of the toxic metabolites which needs to be corrected if you need to have a change in hepatic encephalopathy. Coming to post-transplant, as we have already seen that the skeletal muscle mass remains low even after post-transplant and is also indicative of mortality post-transplant. And the addition of sarcopenia to melt sodium alone also is one of our most robust characters. You can see here that once you add sarcopenia to somebody with a lower melt, you can actually predict that there will be higher chances of physical frailty which is present. And it is also one of the strongest indicators of outcome. So the challenge remains of identification of correction, because even if you do a transplant, there sometimes it is still predictive of outcome. So probably pre-treatment of sarcopenia is one of the important parameters. This was a recent meta-analysis of sarcopenia on survival, and again 1 year, 3 year, 5 year survival, as you can see, progressively goes down. You have a twofold higher risk of death with cirrhosis, and you can also see that if you treat well sarcopenia, that is every 1 centimeter square meter square increase of L3 skeletal muscle, it was associated with 3% decrease in mortality risk. So once you do prescribe a transplant, I think it's imperative that if we can find some solutions prior to that, also that could help in the outcomes post-transplant. The other thing is sarcopenia is a double-edged sword, of course, because it does help somebody to get listed because the pre-transplant mortality is high. You want the patients to undergo curative management. However, because of the prediction of poor model, it could also be a factor to delist a patient from transplant. So it is a double-edged sword at the end of it, and it requires correction. So something that, a short slide on the therapeutic strategies which are still involved. It is supplemental nutrition, exercise, anabolic hormones, ammonia lowering strategies, as well as molecular targets. I won't be going too much into the details. This is a busy slide which looks at all the treatment aspects which are being used nowadays. It is nutritional, ammonia lowering, testosterone. You have the follistin, myostatin antagonists. You have the branch in amino acids. You have withdrawal of other agents. However, it is important to remember that it is the nutrition part of the disease which is important to be taken care of, where you look at the non-obese as well as the obese as to what sort of nutrition that is required, where also supplementation of increased evening snacks is one of the criteria that can be used. Exercise and aerobic, and as we were just shown a while back, exercise is the key to sarcopenia, and exercise is one of the reasons why it is important that we continue with exercise. But the biggest challenge that comes in sarcopenia is not only diagnosis, but how do you monitor patients with sarcopenia? How do you assess that these patients are taking adequate nutrition, adequate exercise, and how does that improve? So that is going to be one of the challenges for both compensated as well as decompensated patient. One common practice that I thought I must highlight is the fact of nil paroler. So what normally happens is that cirrhosis is a state of accelerated starvation. Accelerated starvation means we have decreased hepatic glycogen storage, increased hepatic gluconeogenesis, and what that leads to is that when a cirrhotic patient actually fasts for 12 hours, it is equivalent to starve for 3 days for a normal human being. So our practice of keeping a patient nil parole for various procedures, we do it routinely for endoscopy and other procedures, in fact actually has a negative impact which is comparable to 3 days. And this was done in 1971 itself. So because of the accelerated starvation, that is another thing that should be kept in mind. As I had said, that if you include late night snacks in one of your prescriptions, it does increase muscle mass. 710 kilocalories a day could actually be one of the reasons why you can actually improve muscle mass in patients with sarcopenia. Some of the future directions, so we've been talking a lot about the skeletal muscle, and we've been looking at skeletal muscle as one of the etiologies along with that. But can it be that we can look beyond the skeletal muscle? And this is where something that has been very interestingly been highlighted is the cardiac muscle as well as the respiratory muscle, also called cardiac sarcopenia. So cardiac sarcopenia, as is known, is a reduction in cardiomyocytes with impaired function in the absence of any cardiovascular disease. It could also be part of a normal aging process. However, the cardiomyocyte atrophy and stiffness that is normally caused can lead to changes of cardiomyopathy, also across to increased heart failure. As we all know, post-transplant, even there are certain cardiac changes in nearly 15 to 20% of the individuals. So it is important to even keep this in mind, that while we are looking at skeletal muscle and we are looking at the inflammatory processes, we are looking at myostatin. Myostatin also, by the way, has a role in respiratory sarcopenia, and which is again leads to more increased bacteremia. So this is, and once this even goes to the cardiac muscle, it causes more of LV hypertrophy, more of fibrosis. So again, the identification of probably sarcopenia beyond the skeletal muscle is something that we can probably think in the near future. In fact, one trial which was done, which was a pre-liver transplant muscle loss, was a risk factor for post-liver transplantation, left ventricular systolic dysfunction. We all know diastolic dysfunction above grade 2 is very common post-transplant. That can have some adverse outcomes post-transplant. However, in this study, what they did was they retrospectively analyzed 144 patients. Nearly 88%, that is 15 of them, developed left ventricular ejection fraction less than 55% within 1 year. Neither BMI nor MELD nor the etiology were significant risk factors for development of left ventricular systolic dysfunction. So this is something that has to be kept in mind also while we evaluate, even though at this point of time it is difficult to say what modalities we can use, even though they have mentioned an echocardiogram. Maybe more modalities are required to identify this process. This was a recent thesis which was done by Naveen, which looked at the presence of sarcopenia and tried to correlate it with portal hypertension. He looked 62 patients. He divided them into HVPG of 10 to 15 of 36, 16 to 20, 21, and HVG more than 20 were 5. Sarcopenia, as you say, as more the HVPG, it increased. However, they did not look at the survival, which is something that they could have looked at. They also looked at the arterial ammonia levels, and the arterial ammonia levels are more than 105.5, which predicted the presence of sarcopenia, as well as HVPG more than 14.5. But we still need to understand that sarcopenia can be identified much earlier than what is conventionally thought of. So some of the way forward would actually be the association of pre-sarcopenia in our Indian population. As we already know, we have low muscle mass, so probably the values of pre-sarcopenia, if there is any implications of pre-sarcopenia, can be studied. Whether cardiac sarcopenia actually is relevant and what does it do to the future outcomes, whether we can have AI-based models for the early prediction of sarcopenia, as we saw that muscle-based biopsies and is difficult in patients with cirrhosis. So whether AI would be of some help in this, and whether we can have an application for monitoring once we have diagnosed a patient with sarcopenia, that is nutrition, exercise, which is again a clinical challenge when you are monitoring these patients. So to summarize, sarcopenia has devastating effects on health and quality of life in patients with chronic liver disease. Early identification therapeutics remain the key areas, and robust region-specific data is the need of the hour, and as well as values to predefine what exactly is the reason for sarcopenic population. Thank you.